Okay, thank you and welcome. Today we're in the 13th in the MAHSC Seminar Series, and our topic for the day is Opportunities and Challenges for Artificial Intelligence in Healthcare. We have two speakers who are both Professors of Artificial Intelligence, Chris Yao and Sami Kaski, and they're going to talk one after the other on the same topic. So without further ado, Chris, would you like to start?
Thanks, Sue, for the introduction, and thanks everyone for joining online. My name is Christie Yao. I'm Professor of Artificial Intelligence at Manchester, but also have roles at Health Data Research UK and the Alan Turing Institute. And what I'll be talking about today, together with Sami, is opportunities and challenges for AI in health. And what I'll start off with is first talking about what is artificial intelligence and our particular definition of it that we will use here today. And then also why AI might be important for healthcare applications. I'll then talk a little bit more in depth about the concept of supervised learning and the deep approaches towards supervised learning. And then I'll start talking about some of the evidence requirements that are emerging in terms of translating some of these technologies to real-world clinical applications, and some of the challenges of making AI systems work with real-world data. And I will end my section by talking about a couple of emerging applications which I think are exciting. In the second half of this session, Sami will then talk a little bit more in detail about AI in Manchester, and about his personal interest in personalization in AI-driven healthcare and human factors. But what I'd like to start off with in these types of talks is to talk about artificial intelligence and what it means. And I think this is important for us to kind of think about this first, because the definition of artificial intelligence or AI has really broadened in recent years. Classically, AI was mostly concerned with the idea of how we think about general intelligence and logic and reasoning, neurobiology, cognition, and linking that with theories of computation and information theory. Some of this touched on issues of philosophy and ethics as well. But in the kind of more modern definition of AI, which is now broadened, it's now more driven perhaps by more problems, applications, and the use of data, and how we can bring about computational science and engineering to make algorithms that don't achieve sort of general intelligence, but are able to perform specific tasks. So there's been a transition in terms of AI and how it's perceived as being from a specialist fundamental field of study to something that is more mainstream, more application driven, and more of a major science and technology enterprise. Now, within that kind of context, what do I work in and what does Sami work in? And actually we have mutual interests. And the particular kind of subfield of artificial intelligence that Sami and I are interested is perhaps more widely known as machine learning. And what's our kind of definition of machine learning? And it really rests on kind of three pillars. We're interested in statistics, and statistics is of interest to us because it provides us with a rigorous mathematical foundation for handling uncertainty when we're dealing with data and making correct inferential questions and subjects and constructing models. We're also interested in computational science and the formalisms and methods that are required for implementing potentially dynamic, scalable, and potentially interactive algorithms. But what's been of sort of a major advance in the last 10 years that has helped us sort of bring the statistics and the computational science together is what I call infrastructure. And this is an umbrella term that I use to refer to the wider availability of data, computational hardware, and software frameworks that allow us to construct reproducible and rapidly develop and deploy AI systems and to evaluate their effectiveness in real-world usage. And a lot of that infrastructure has been driven, via two streams. There's a significant amount of effort that's been invested by the open community to develop software tools that enable us to construct AI systems more quickly and more readily. There's also been incredible backing by the big tech industry, and I won't name who those are, they're very familiar names to us, who have put in significant resources into developing what I would call the underlying plumbing for the AI development that we do. And against that kind of context, why has AI and health been, somewhat one of the perfect marriage in some sense? And what has kind of supercharged excitement and interest in these applications and launched potential paradigm changes? Well, there's been a number of developments over the last kind of 10 years, but perhaps, one of the major events that kind of triggered excitement was back in 2017, 2018, which seems like a long, long time ago now, but it's relatively recent, was when Google DeepMind entered the health AI domain and produced two papers. The initial one with Royal Free, looking at acute kidney injury, that was more digital health. But there was a second paper a year later where they looked at OCT images obtained from retinal scans, working with Moorfields Hospital, and brought deep learning to the analysis of these types of images, and showed in their paper in Nature Medicine back in 2018 that they could produce AI systems that could analyze these images and produce clinically applicable outputs. And with that kind of big tech backing and entry into health AI, that triggered, an avalanche of interest in the opportunities for AI in health. And perhaps, one of the main sort of spokesmen for that area was Eric Topol, who then went on to write the Topol review for the NHS, looking at how the NHS could evolve digitally in the future. And perhaps more recently as well, in just the end of last year, again, Google DeepMind made another kind of splash in our kind of consciousness in this area by providing a system that was able to fold proteins, predict protein structures with greater accuracy than had ever been attempted before, extending the range of possibilities for AI in healthcare, now away from just perhaps clinical image analysis or text analysis, right down to potentially systems that could help us to design new drugs and therapeutics as well. So these were examples of events in the last kind of 5 years that have kind of really brought AI to the forefront of healthcare kind of thinking. But now I want to kind of talk a little bit more in depth about, the actual underlying technology that underpins these things. And many of the applications in healthcare AI at the moment tend to center on a problem known in machine learning as supervised learning. And what is supervised learning? Well, in supervised learning, the objective is that we have some inputs, maybe say, for example, in this case, mammogram, an image. And we want to construct an algorithm or a model that maps that image to a particular output. And suppose we're in a kind of breast screening scenario here. My input is a mammogram, and my output may be a recall, no recall decision as to whether that particular individual should be recalled for further investigation because we've detected potential lesions in breast screening. So the idea of supervised learning is that if I have a series of mammograms and I have a series of output labels that are already being given to us and categorized, then somehow I want to create a model or algorithm that learns from these exemplars and then can be applied in a test setting when I have a new image come in and I don't know the outputs, but it can then predict the output in that testing. Now, the classical approach to kind of building that model, that kind of box that goes in between the inputs and outputs, might be to do something like build an image model. So we might use some knowledge about how the images are acquired. In this case, it might be how an X-ray passes through the variable density and different tissue architecture of the breast, and to specify, what differentiates potentially cancerous lesions from normal breast tissue, and then to encode that in an image model that we can then use to predict, given any other new mammogram, whether to recall or not to recall that patient. So the idea of from classical image modeling is to identify characteristics of the image that might indicate cancer. And I call this sort of classical modeling. This really, would have been state of the art, not just 10 years ago. And Sue here was a world leader in that type of work. But in kind of recent years, a new paradigm has emerged that has kind of swept some of those old ideas aside. And that's those ideas come from the field of deep learning. And the idea behind deep learning is that perhaps we don't need to come up with these kind of image models. They require a lot of knowledge about the underlying physics potentially. Yes, they may help you learn with limited data, but it requires a lot of specific expertise. Perhaps we can turbocharge this supervised learning paradigm by just looking at applications where we can find lots and lots and millions of potential exemplars, lots and lots of already labeled data sets where for each input, I already know the output. And then if I can apply a model which is sufficiently dense and complicated and flexible, perhaps I can learn from this extremely large data set how to match essentially inputs to outputs. So instead of worrying about what the physics are of that might be sort of generating these images, what we're trying to do is instead solve perhaps a simpler problem, which is simply to find a matching algorithm that matches images to their correct labels in this particular case. And it turned out that the effectiveness of deep learning is actually surprisingly good for many, many types of applications. What underpins deep learning is the use of these things that are shown here on the right, which are neural networks. And these networks essentially consist of individual neurons, which you can think of as just a very simple data processor. But if we can network lots and lots of these neurons together to create these deep neural networks in various architectures and in many different creative ways, people have designed these architectures. If we can network them together, the collection of these neurons then have the capacity to learn the underlying explanatory patterns from very large data sets if we set it with a clear goal to make a certain type of prediction from the inputs. And what we found from applications of deep learning is that when we give it a very specific task and we train these algorithms to solve that task, that these algorithms then do really turn out to find explanatory patterns which often correspond to intuitive ideas of how we might interpret the data. So in images, for example, the layers of these neural networks might learn to interpret edges, facial features, if we're looking at kind of faces. But in the case of mammography, it learns from these examples how to pick up the features that are associated with cancerous lesions. I think one of the attractive features of deep learning, and perhaps why it has been so appealing for a wide audience, is that it has made solutions to these types of machine learning problems more accessible to a wider audience. You don't need to have specialist knowledge in image modeling or the physics behind how images are acquired. All you need potentially, if the paradigm holds, is a large collection of labeled data, a flexible model, and all that computing power and the software frameworks that I discussed earlier to help you to build the algorithm. And these deep learning systems have been surprisingly useful in uncovering some unexpected findings. So for example, if we talk to an experienced ophthalmologist, they would probably tell you that from a retinal fundus photograph that they, no matter how much experience they have, cannot tell whether that image comes from someone who is a male or someone who is female. They just cannot do that classification task. But it turns out, and there are a number of studies, and this one comes from PSQ and more fields, is that if you train a deep learning algorithm to predict gender from retinal photographs, that it can actually do that with a high degree of success. And this has been replicated in a number of studies across the world. Why is it able to do that? Well, ophthalmologists don't quite know because they can't do it themselves. But somehow, by building a machine-based vision system, the algorithms are able to detect gender-specific features. And these kind of findings are replicated in other applications as well, where by constructing a machine-based vision system, we're not restricting ourselves to the rules that govern our own human vision system, which has evolved to essentially process visual information in a limited way. It has been, these deep learning systems have been able to extract features that we as potential humans do not perceive. And similar things apply to other data modalities as well: text, audio, ECGs, molecular data. So why are we not using AI everywhere for healthcare applications? But why are we not seeing more use of it more widely? The question here is that AI systems are essentially medical devices, software devices. And at the end of the day, what we need to do is prove that those medical devices are safe, they're robust, and ultimately give meaningful patient benefit when we insert them into clinical pathways. So for example, if we're interested in mammography and we're interested in breast screening, one example of an AI application might be to replace the second reader in the UK kind of breast screening protocol with an AI system who takes the place of a human being. Now, the question is, if I do that, how do I measure, what do I measure to understand whether that replacement of the human with the AI system gives me the right set of outcomes and show that the whole system is still safe? How do I measure the efficacy of the human AI interface? If I have an arbitrator who has to decide between conflicting decisions by an AI reader and a human reader, how will they react? Will they react differently if they're adjudicating between two human readers? How do we tell if the AI system may have produced biased inputs because of the impact of confounders? And how do I build an evidence base, potentially using real-world observational data to prove the efficacy of my AI algorithm? Or is it the case that I have to jump immediately to prospective gold standard randomized control trials? And this is a project that I'm working on with the Alan Turing Institute and Chiron Medical Technologies to kind of tease out solutions to these types of questions and others to understand how AI systems differ in terms of its assessments compared to other kind of medical devices. But why might artificial intelligence solutions not work, and why might we want to assess their robustness and safety, given that I've kind of told you that they seem to do really well in many types of applications? Well, in real world usage, we need to worry about three things. The first is generalization capability. And what I mean by that is whether these AI systems have been over-engineered to work very well in a specific context, but then do not work in other situations. So I might develop a fantastic AI system that works in hospitals in Manchester, but then I move that system, say, to London or Birmingham. The system may not work too well because unknowingly and implicitly, I've engineered a system that actually is overly tuned to whatever the context was, environment was that I had in Manchester. So generalization capability is an important factor in the development of AI systems that might work universally and not just purely in the context in which it was developed. We might also need to worry about distributional shift or unrepresentative data. So if I'm developing a system purely off data, and then at runtime when I deploy it in the real world, the data that I see does not have the same characteristics that were used to develop it, then I might see output which contains artifacts or biases or erroneous classifications at test time. So this is kind of important in addressing potential population shifts particularly if the social demographics, for example, of the data that I use to kind of develop the algorithm differ from the social demographics of the patients that I might then apply the algorithm to. And the third major reason why AI systems might not work is just a very classical statistical concern, which is confounders. So the assumption is that for any given input, I have an output, and I can design a system that maps one to the other. But we know from sort of epidemiology and biostatistics that if there are confounders that might affect the inputs and outputs, and some of those confounders may be measured, they may not be measured, that the presence of these confounders might introduce spurious and distorted associations. So in the interpretation of these AI systems and these outputs, we have to be careful about treating correlation as potentially correlation, and that may be an incorrect assumption to make. And in particular, in data-driven systems, which deep learning systems are, we need to be wary of the fact that because these systems are driven by exemplars, that any technical biases or artifacts that are contained in these exemplars will be translated into the AI systems. It is, at the end of the day, doing a matching exercise. It's not trying to understand how the data was formed. It's ultimately trying to map inputs and outputs that it sees in the data that it's fed when it's being developed, and then reflect that at runtime. And these kind of concerns are particularly pertinent in the understanding and sort of analysis of electronic health records. And why would that be important? Well, the first thing to realize is that an electronic health record is really a record of an individual patient's encounters with the health system. And those encounters may give rise to different diagnoses, prescriptions, lab tests, and other kind of diagnostics. And because they are recording interactions, they are likely to be irregularly sampled. They're not going to have data at regular time points. They may involve a mixture of data types. And they may involve what people tend to call missing data, but I don't like to call it missing data. But they may involve what people call missing data in the sense that at any given time point for any given patient, I might not have any information associated with them. And the fact that there's no information associated with that patient at that particular time could be an informative thing. So an individual who has fewer healthcare encounters is either someone who is relatively healthy and therefore doesn't need to see a clinician, or for whatever reason, they are ill, but not engaging with the healthcare system. So there are data challenges in terms of using electronic health records and trying to derive prediction algorithms from these kind of heterogeneous, irregularly sampled data. But there's also a causal challenge in terms of understanding this data, which is to realize that all these events that we're recording arise from a very complex interaction between a patient's health state, the underlying risk factors, the various clinical interventions that are being undertaken, and of course, unobserved factors that are not recorded in the electronic health record. And what this means is that there are very subtle but important implications for the development of prediction models, and in particular prediction models that might try to tell us alternative outcomes under alternative interventions. In order to develop those prediction models, the very standard kind of supervised learning paradigm don't really work. We need other tools that are able to unpack the fact that the electronic health records contain all its complex interactions before we can design those prediction algorithms for alternative interventions accurately. And Niels Peek and his team in Manchester in health informatics have been doing a substantial work in this area. And nationally, I'm involved with projects with Birmingham, St Andrews and CPRD, funded by NIHR and MAHSC, to look at this on a kind of national scale as well. I'm going to end my talk before handing over to Sami by mentioning molecular medicine, which is a personal main interest of mine, and to highlight that I see molecular diagnostics as potentially a defining area for AI in health. And this is because many of the kind of technologies that we use in molecular diagnostics produce very large, high-dimensional, complex heterogeneous data sets which occupy multiple scales, tissue level, subcellular level. And we're using this in a research setting to understand causal mechanisms and the biological underpinnings of disease. But when we translate them into the clinic, what we will see in the years to come is increased use of these kind of molecular technologies to help us track the progression of disease at the molecular level, and perhaps to integrate molecular diagnostics with therapeutic design so that we can customize therapeutics based on an individual's molecular characteristics. And the importance of this type of interaction has been emphasized very recently in the last week by the UK's genomics implementation strategy, and something that in particular based from a UK RA fellowship that I was awarded last year is something I'm particularly looking at. And I think it's really important to emphasize molecular medicine and the use of AI because from the very outset in the world of molecular medicine and omics technologies, computational analysis of this data has been very important. Unlike sort of images or text, there are a few alternatives to computational analysis of this type of data. I'll now hand over to Sami for part 2 of this talk.
All right, thanks, Chris. Let's see if I can share fluently. Now I'm assuming you can see my presentation slide and can hear me. Hopefully somebody will write something in the chat box if you can. Now I can actually see the chat box if you have questions. So yeah, Samuel Kaski, I'm professor of AI in 2 universities, Manchester and Aalto University in Helsinki, where I'm running the Finnish Center for Artificial Intelligence with the partnership between the 2 universities. In Manchester, I'm a research director of the MAHSC Institute. I'll tell something about that. So I'll start briefly by the opportunities that there are in AI in Manchester, and then talking about the human-in-the-loop types of approaches that Chris mentioned. So in Manchester, so what do we have at the moment? There is broad research power of AI-aware researchers across fields at the university. So depends on how we count, but according to some calculations, 900 researchers working on AI. And that would be the Institute for Data Science and Artificial Intelligence. So nobody can do this big thing alone. Already the things that Chris was mentioned require lots of partners. So what we are partnering with is the Alan Turing Institute nationally, and I'm mentioning a couple of things that I am involved in. In addition, there's of course many others. There's the European Laboratory for Learning and Intelligent Systems, ELLIS, which is a network of arguably the best machine learning related centers across Europe, designed to make Europe attractive to the best future talent in this field. At the moment, Manchester already has several people working on fundamentals of AI, including Chris and myself. And most people who are working on fundamentals also work on applications. They go very nicely hand in hand in machine learning. There will be new recruitments. Some are already ongoing. Manchester is going to be stronger in this field. So there's big plans underway. Of course, health now being one of the main applications where Manchester is very strong. This partnership between these 2 fields, at least I'm putting high hopes on that. So what is the Manchester unique opportunity or particular opportunity? Is in connecting the top-notch health research to the burning health and care needs with AI as the engine, or as one of the engines. Maybe this is more of a hybrid vehicle where AI is one of the engines, maybe a main engine remains to be seen. And how this can happen, that is where the MAHSC Institute has a key role. So it's Institute for Health Technology Research and Innovation, which sits in between of the 3 faculties and is focusing especially on enhancing translational research, really taking things up to practice, connecting the basic research in different fields to practical outcomes. What is needed for that is we need data, we need ease of use of the data. This would be the part of the infrastructure that Chris was mentioning, and links to both, of course, healthcare providers, companies, AI companies, to partner with in producing the final products and services. So that's the vision. Bankhurst helping do this, and of course the top-notch researchers actually doing the stuff. That's the opportunity, and for some reason the slide doesn't change. Now it does. Then on to the human in the loop approaches. So I would start this by saying that we need to personalize. Whatever we do, we need to personalize. And if I start with the personalized or precision medicine, which Chris already had in his last slide, so molecular medicine meant for making more precise diagnostics based on cellular measurements, including genetic measurements. So tailoring treatments to individuals. In this problem, in the core of this problem is actually a data analysis challenge. So based on a data set with known answers, treatment effectiveness, learn a predictor for the effectiveness for new patients. So it's a data analysis challenge, which is at the same time a statistical challenge. So the core problem is that we have typically too few samples compared to the number of potentially important variables that there could be. So deep learning can do miracles if the problem is well set. This is what Chris already covered, and if we have enough data. But now we don't always have that. In rare diseases, for instance, we don't. So we need to have some additional ways on how do we regularize these solutions, and those would be personalization to the patient. Personalization, obviously, not only to patient, also to other people who want to just make better life choices or want help with life choices, and which is not a new idea. Like personalization is not. Even early Nokia phones, which are now almost extinct, they boasted with having health assistant apps, and obviously there are lots and lots of different applications at the moment. So lots of opportunities. Of course, personalization is not only a data analysis task. So now we have been covering the deep learning types of approaches. What can we do just based on data? And then if we can personalize, what can we then do better for the patient? Somewhere we do need still doctors, and we need medical researchers. So none of you guys will be replaced. So domain expertise needs to enter somewhere, otherwise these problems just can't be solved. There is in machine learning, there is even a theorem that is called no free lunch. It says that you can't do any modeling without assuming something. And what the assumptions are, they are exactly the domain expertise. So the question for people such as myself who are developing methods is that we now know that domain expertise is necessary. Can we help somehow getting the domain expertise in the models so that the predictions would be better, and in a sense doctors could be better doctors with these tools than they would be without these tools? And that's an obvious synergistic goal for all of us here on this call. All right, for some reason, again, I have problems with the slides. Apologies for that. There should be some way for me to scroll back, but that doesn't work now. Sorry about that. I hope you can still see the presentation. So we need to personalize both to the expert patient and the experimental designer or the researcher, medical researcher. And how can I help in that task as a machine learning researcher? I can develop techniques that ask questions from the expert in the hope of building a better model that would then be better predictive of effectiveness of a treatment, for instance. Here's an example that we built a couple of years back, which is designed to be the simplest possible system we can think of. And that's why the questions are very simple. But the questions can be as general as we can think of. For instance, the system can show plots about effectiveness of a treatment compared to other patients, bring up alternative patients, earlier patients with known outcomes, and so on. Those all are questions in this sense, or queries. In this case, the question is the simplest we can think of so that we can demonstrate performance easily with the machine learning methods. So in this case, the task is to predict effectiveness of treatment of a specific drug based on genomic variables and clinical variables. And the question the system asks the expert is that, do you think that this particular clinical variable might be helpful in improving the predictions for this particular drug for this particular disease, multiple myeloma in this case? Then the system goes and updates its model and decides what is the next most informative question to ask that is still easy to answer for the expert. And as a result, as the number of questions, which is the x-axis here, increases, the predictions improve, as you can see. And after about 1% of possible questions, the performance improvement is 70% of the available improvement. So this actually is able to help squeeze out experts' knowledge with minimal number of questions to the system. So that's the simplest example I can come up with of a human-in-the-loop system. More generally, we would be building decision support systems which are designed to present the results such that they are maximally useful for the decision-making task that the expert has, which is typically, of course, not predicting in a naive sense as what deep learning systems would do, but instead doing the clinical diagnostics and deciding on the treatments. For that, it is not sufficient to consider the user as just a data source, which these human-in-the-loop approaches would typically implicitly assume, that we people are just data sources as any other data sources. For a system, of course, ultimately that's what we are, but they are making too many simplifying assumptions if they are just assuming that. So instead, we would, of course, want to have systems that would actually help us in whatever we are doing, in our goals. So how would an AI then know what my goal is? What do I need? So I suppose many of you have used Alexa, and it's perfect if we need to verbally ask it for playing a song, a specific song where we know exactly the artist and the name of the song. If you've tried to make Alexa do anything more complex, if you don't remember the song completely, or if you try to make it do something completely different, such as I had hard time trying to make Alexa stop. For some reason, it stopped understanding my accent, and there was no way for me to tell it to stop. I just had to try all different variants of stop, shut up, and so on, and nothing seemed to work. And the reason why it can't be helpful in these cases is that it is essentially, it's waiting for data. It's sitting there and waiting for a specific command. And if that command never arrives, then it will not know what to do. Whereas we people would solve that problem probably by the third time. Somebody would understand that, yeah, I actually have a specific thing in mind, but I would, for instance, ask that, did you mean A, B, or C, or something else that I didn't understand? Now this doesn't seem to converge, and you could quickly then say that, yeah, I meant B, or not quite, but almost. This is what Alexa can't do because it doesn't have a user model. It doesn't have a model that would assume that the user has a goal, but Alexa just doesn't know it yet. That's why it can't help the user find the goal. So we need user models. And an example of more practical or concrete and practically useful example would be drug design, where the most advanced current AI tools are able to produce candidate drug molecules when the user gives them a chemical objective function to optimize. But the difficulty is that we are not very good at writing down such functions. So we would need to have a system that would help us write those functions, or better yet, if they could assume that we have a goal which we cannot really easily verbalize, and it could help us narrow down on what we really mean by our goal. So an assistant which would have such a user model would be able to, for instance, ask me as the user by showing a set of candidate drugs, asking for feedback, and then choose again which candidates it shows until we are narrowing down on something sensible. And then here the assistant can now help the user by showing also additional stuff which are easy for the assistant to show, whereas difficult for me to know is, for instance, simulated results on how this particular molecule would work in the body, or how to which other potential targets it would bind, and so on. So more generally, and this is where I'm intending to conclude, is what I am trying to now convey is a vision where instead of AIs just building a model of the world, which in this case would be of the patient, the chemical measurements of the patient, or molecular measurements of the patient for personalized medicine, for instance, which is a standard machine learning or standard AI. Instead, we would want to realize that usually there is a user, there is a decision maker involved sooner or later, and if we developers of the machine learning AI systems can realize or build systems that realize that it's the user we are ultimately helping, then we can actually build the AI so that it helps the users. We don't have to find weird ways of using the AIs afterwards, but instead we can build assistants that model both the user and the world jointly, not only the world, so that they can predict how the user would understand the recommendations the AI makes, and would they actually be useful in the user's task. And they would be able to narrow down on what the user's task actually is, instead of just operating on an assumption what the task could be. That's it. And I'm very glad to take some questions, as I'm sure Chris will as well.
Thank you to both our speakers. Yes, there are quite a few questions in the chat. Perhaps we can start by asking you, so a very basic question is AI a threat or an advantage? Some people may lose their jobs or be reluctant to use it. How do you deal with that kind of suspicion?
Maybe if I can start and Chris can continue. So yes, so AI will probably, the availability of AI will change our jobs quite much, as any tools, because of course we can do our jobs better if we have better tools, and it would in fact it would be unethical, not in healthcare, not to use better tools if we can cure patients better with the tools. So some changes there will be. And the most radical quote that I have heard is that AI will not replace doctors, but doctors who use AI will replace doctors who don't.
Thank you. There's a comment by Chid who says a BMJ article found that AI gave biased results, and different methods gave a different risk predictions for individuals despite similar population performance. And aren't we over optimistic in clinical applicability of the methods in clinical data at the moment? I think you can probably see that one in the chat.
Yep. Sammy, do you want me to take that one? Yeah, so I think even given the same data, there are a variety of different methodologies. And the thing that I teach my students is that it's not just what's encapsulated in his name. It doesn't detail you what's actually going on under the hood. So all of these kind of methodologies make certain assumptions about how the data is generated and properties about the data. And the outputs are therefore dependent on that interaction between the assumptions made in the construction of those models with the data. And therefore, it's not, it's entirely, reasonable that there are different methods, reports different kind of outputs and may have different biases. I think for me, the thing for me is, we can construct methods and then we need to evaluate them in a principled and a robust way. And there are a variety of strategies for doing that. The key thing is, whatever it is that we want to use it for clinically, we need to make sure that it's safe, it's appropriately calibrated to tackle the task. And it may be that there's more than one solution to the same problem, and they both have slightly different characteristics. But what we want, is to apply, principles of engineering to this. We need to set thresholds and tolerances for what is acceptable. And as long as solutions, balance and sit between those thresholds, then they could be clinically useful.
Thank you. There's a question that's been asked about what AI is currently used in healthcare. So can you give some examples of current AI systems?
It's good if you, Chris, can answer this. I suppose that even your systems may be in use.
I'm trying to think of like
I can
real
think
world
of
examples. Yeah. There are things in development that are reaching experimental trial stage. Whether there is a headline kind of technology which is actually being deployed for use, I can't think of any example off the top of my head. There may be some embedded within other systems that are kind of running in the background. So, for example, ICU monitoring hardware may actually contain algorithms which, under different circumstances would be considered to be machine learning or AI algorithms. So there may be systems which are embedded within hardware systems or etc. But I can't think at the moment of standalone systems simply because we don't have the regulatory framework in which to permit these systems to be deployed, at least in the UK anyway.
So
image analysis.
Yeah. So I was just going to say a couple have popped up in the chat. Derm AI, skin analysis tool, and predictive algorithms used in intensive care or resuscitation in burns patients in the USA. Thank you for those comments.
Yeah.
Sorry, Sammy, you were about to chip in?
Yeah, I was going to say that in image analysis, I'm aware of a few, but I would like to add that I don't think we should see AI as some kind of dark art here, which is kind of, some methods are AI and some are not. I mean, the most successful machine learning tools are really advanced statistics and are being used as standard parts of the toolboxes.
We've had a couple of questions asking whether there are any AI models using CPRD data, that's anonymized GP data. Are you aware of any, or have you implemented any?
For my work, yes, we are developing various things. I think I mentioned it in one of my slides, using CPRD data. There are numerous people around the world, in the UK, who have used CPRD for the development of AI algorithms, particularly in the prediction kind of setting. I'm not aware of anything which is, has resulted from that kind of research and has then been used in the real world yet. There's purely a development that I'm aware of at the moment.
And Chris, you touched in your talk on the difficulties of using representative data sets and appropriate data sets. The question came up about avoiding bias caused by training, particularly on Caucasian populations, which seem to be the easiest to get one's hands on. But would you like to comment on that?
Yeah, I think this is always a difficult question for people like myself and Sammy. In some sense, if the data is biased, we can't solve that problem using AI. There's no magic wand to solve that kind of issues. All we can do is, hopefully in a very robust way, take into account that there are these potentially different demographics in the data and build that information in. But if my population is 99% Caucasian, there is no magic box or free lunch, as Sammy calls it, to solve that particular issue. We just need to collect more data on those underrepresented populations.
And I guess that links to another question, which was about the fact that there's a lot of AI applications being developed for well-resourced first world countries, and how might AI applications be used in low resource settings?
Right here, yeah, okay. So there are, I would divide this in two now. So there is the kind of Google scale applications, which require computational resources that are out of reach of any of us normally, right? Except for special projects maybe. But then there's the mainstream of AI applications, which is doable with standard computers ultimately. And now there is an argument that in this field is very different from many other fields, that there is a long tradition that everything is open. So the algorithms code are completely openly published. And there is the additional benefit for many of the countries who didn't build all the intermediate stages of the infrastructure, landlines and so on. They are jumping directly to the next stage, which makes them comparatively slightly less disadvantaged with these new technologies. Of course, the gap is still there, but I don't think that AI is here the extreme in a way that we first might think. It might actually be that it is an opportunity for catching up a bit.
Thank you.
There's also a reason why Sammy and I work on fundamentals of AI as well, is that sometimes we come up with better mathematics to solve these problems, and that reduces the computational burden considerably. So we don't always necessarily just have to say we need a bigger computer to solve a bigger problem. We just need to think harder about the mathematics and solve it that way.
So while we're on technical questions, there's a question at the end from iPhone 2. I'm not sure who iPhone 2 is, but they're asking, any idea on how to introduce causality into medical data processing?
So Chris, you had something about that. Do you want to start?
Yeah, so I mean, from my perspective, the way I approach it is, you would approach it as a statistical modeling exercise. And go from there. We have well-established, theory and methodology, particularly from the world of epidemiology, about causal modeling. And there's various pieces of work, significant pieces of work like Judea, Pearl, etc., on this area. And we start constructing models based on those principles. And my particular kind of interest in this area is, given those principles, how then do we add in modern sort of tools and methodologies to augment those classical kind of ideas from causal inference, which might be dependent because back in the 80s or 90s, we didn't have the computing power to process larger data sets or deal with bigger models. How then can we use modern methods and hardware to soften and relax some of those assumptions that back then, many years ago, were required to make the mathematics tractable, and how we can use kind of modern machinery to kind of relax those assumptions and to make models which are flexible, but are still based on those kind of causal principles.
There are a couple of questions about whether or not the use of AI will lead to more self-management of health, and how that might work?
It will enable more self-management. Whether it's a systemic issue, whether we will go there, right? But yeah, it might be worth thinking. I'm a layperson here, but it would be worth thinking that can the persons actually do more themselves if they want to, and to what extent will the end outcome be better? I think a kind of trivial example where it would be better is for those who want to collect data of their patterns of life, which would be background then for more advanced decision making. Of course, it would make sense to enable them if they want to do that.
There's a Manchester-specific question. Within Manchester, what challenges and solutions do you envisage in multimodal high-volume data transfer between the multiple clinical settings in the trusts and the university, and how could that be better facilitated?
This is a difficult one. So at least I'm not an expert on how to actually do that, except for one particular aspect. So there is, I'll just tell that, even though I know that this is a bit of a side issue, even though important issue, is privacy of the data. So that's a basic research question that we are actually studying on how could the data be shared, distributed and shared, and at the same time guaranteeing that privacy of all individuals whose data there is protected, so that it's no way possible from the data to detect whether individual person's data was there. So there are new technical solutions for this, which will make this a bit easier in some cases, but it will not solve the whole issue. The other thing I can say is that this is very much, part of this problem is very much on the agenda of the MAHSC Institute, because it's obviously a big opportunity if we can solve this issue and leverage the collaborative opportunities here.
Thank you. And as a final question, where would you recommend that researchers or clinical, non-clinical staff go for further support or training in AI to help with their work and their treatment outcomes?
We don't quite yet have the one-stop shop for this, but this also is something that MAHSC is aiming to facilitate. And the answer is it needs to, of course, have several sides. So collaboration will help how to do the collaboration so that it's maximally beneficial for everybody. And then that there would be different kinds of training and joint working opportunities for people who have different needs, which is obviously very difficult to arrange, but let's see what we can do.
Thank you. And we've reached the end of our allotted hour now, so I would like to thank both the speakers on behalf of the audience, and thank you all for coming. Thank you.